Hello guys, can you hear me clearly?
Yes, we can.
Hello everyone.
Hello, Dr. Mars.
Hello. Okay, so I don't know for what weird reason Dr. Ahmad did not share the second day hematology schedule with me. So I'm gonna start from day three, right? We do the day two in the end. I think he labeled it as day three. It's actually day two, right? Hmm. Okay. So let's go. Let's start. So today we are gonna do coagulation disorders, von Willebrand disease, and hemophilia. Oh, we've already done.
We did this yesterday,
Yeah,
hemophilia.
yes, we did it. I don't know. Okay, so basically we did extra yesterday, right? So we were only supposed to do platelet disorders and thrombotic microangiopathies, right? But we did hemophilia as well in the advanced, right? So yeah, we did extra. No worries. So one topic that we'll do today is von Willebrand disease, right? Hemophilia is already covered. right? Coagulation disorders are already covered, right? So one thing that we're gonna do is one will brain disease, right? Let me open up the first page so I could just show you where do we wanna start, right? So basically, we started immunology from, sorry, not immunology, hematology from. Let me wait. Let me give a second. Yep. Okay, let's cover everything. Okay, so we started it from here, right? Hmm. We started it from here, the coagulation disorders. These are done.
Dr. Mas,
Yes.
I cannot see your screen.
Okay, sorry. I'm getting a new setup for you guys, right? It's gonna be a much like I'm gonna do another type of like I'm gonna do some more things for teaching, right? So things get better, right? It's gonna happen soon. As soon as I get my apartment, I'm gonna make things better. And so this is basically my second last day of nights. Tomorrow I'm off, and after that I'll have one more day of night. So after that, my schedule is gonna be much easier, right? So I'm gonna be more consistent. So the hard days are gone. These were the most hardest days for me. Okay, so first of all, we are going to do mixed platelet and coagulation disorders today. We are going to do hereditary thrombophilias, right? And we are going to do blood transfusion therapy. Okay, we are going to do all of that. Plus, I think we can do more, right? We can do more, right? Let's do lymphomas, Hodgkin lymphomas, right? We are going to do the Hodgkin lymphomas. Okay, okay. Just to make things faster for you guys, right? I want it to end in a good way. Like, let's start the first one. One will brain disease, right? So, anyone can tell me what was the role of one will brain factor in clotting?
Adhesion.
It helps adhesion of platelet to the
How
endothelial
does
cells.
it helps in adhesion?
It binds with GP1B.
Okay, so it's bind with GP1B, right? Excellent. So it's gonna bind with GP1B. Adhesion is not gonna happen, right? It's gonna reduce the adhesion. That is the first thing. Second thing, it protects the factor VIII. Von Willebrand is a protector of factor VIII, right? So if von Willebrand is not present, what is gonna happen to the factor VIII? Will it increase or decrease?
Decrease.
Decrease.
Will decrease.
It will decrease, right? When it will decrease, right? What parameter of the body would be disturbed?
APTT.
DT. Oh,
PTT.
for
APTT and bleeding time.
APTT, factor 8 APTT.
APTT is gonna be affected. Remember, bleeding time. Yeah.
Intrinsic.
So for platelet, for this, it's gonna happen, right? The bleeding time is gonna be affected too. I'm gonna tell how, right? So two things. One is this, that obviously the adhesion is not gonna happen. The second thing is that factor VIII is gonna. So now the question comes, right? This is the most important question, right? APTT has been increased, right? How do you decide if it's von Willebrand disease or hemophilia?
Because the bleeding in
We'll
von
check
Willebrand, it's
bleeding
In
time
cutaneous.
too.
It's
in uh,
cutaneous.
in, in
And in
hemophilia, bleeding
hemophilia,
time
it's
won't increase.
No, the question does not mention bleeding time.
actually the bleeding in the von Willebrand, it's like cutaneous, and in hemophilia, it's like visceral.
Excellent, right? Until till I did my after my step two. In my step three, I came to know this thing, right? So after like 2 or 3 years of studying, and like at this point, it's excellent, right? So the main thing is that there is gonna be a visceral bleed in hemophilia, right? So the bleed in hemophilia is visceral, whereas the bleed in yeah, what is the other thing? Yeah, von Willebrand disease, it's gonna be cutaneous. What does not exactly cutaneous? I'll tell you what I mean from that, right? Okay. So basically, in case of von Willebrand disease, the bleeding is gonna occur in two places, from the nose or from the uterus. So the patient is gonna have increased amount of epistaxis, or the patient is gonna have increased amount of menorrhagia, increased amounts of menses, and increased amount of bleeding in menses. Right? Whereas in case of hemophilia, the bleeding is gonna be present in knees, in joints, in elbows. In those areas, the bleeding is gonna be more prevalent, right? There's gonna be bleeding from the gums as well. This is a serious bleed, right? So this is the difference between both of these. Now, if I move on to the next thing, right? The next thing is that how do we treat this thing? In order to treat this thing, we give the patient desmopressin, right? So what does desmopressin does? Desmopressin is gonna release von Willebrand factor, right? If von Willebrand factor is released, the patient is gonna get better. So in von Willebrand disease, von Willebrand factor. So basically, there are different types of one. Okay. Basically, my this evaluation this week was on von Willebrand disease, right? They asked me a lot of questions about this. So there are different types of von Willebrand disease: type 1, type 2, 1A, type 2B, type 2C, type 3, type 3A, type 3B, type 4, right? But we are not going to go into the detail of that. For you guys, this thing is enough that von Willebrand factor is not working, or its quantity is reduced. One important thing that I need to tell you guys, I don't think we are going to study it anywhere else, right? So if this is a heart, right? This is the right ventricle. This is the left ventricle, right? I'm gonna take your test, right? So the question that is important here is this, guys. Hmm. Okay. So the question here is, let me ask you this. If a person presents you, person is 65 years of age, and he has a crescendo decrescendo systolic murmur at right upper sternal border, what is the most likely diagnosis?
Aortic
Aortic
stenosis.
stenosis.
Okay, aortic stenosis. And now, if I tell you this person bleeds a lot, what is the most likely diagnosis? This person is bleeds a lot. This person is having anemia. This person is having epistaxis. What is the most likely diagnosis?
It sounds horrible.
Is there an association between these two?
Mm.
Hmm? Anyone?
Microangiopathic hemolytic anemia.
So let me tell you. Yes, when a person is having aortic stenosis, right? This area is narrowed, right? When this area is narrowed, whenever the blood passes through it, right? One important thing that happens is that von Willebrand factor is cleaved, right? One Willebrand factor is very sensitive. Whenever it's gonna get destroyed when it passes through it, right? And when it gets destroyed, this patient is gonna have bleeding, all right? This patient is gonna have bleeding. Okay, is that clear?
Is this in patient with deficiency of von Willebrand factor?
No, 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 no. I'm saying if a person is having aortic stenosis, there is a lot of chances this person is going to have a deficiency of one Willebrand factor. And what is the reason this patient is going to have a deficiency of one Willebrand factor? Did you get it? Anyone? I just told it, guys.
Yes, I
Yeah,
have it.
it's because
What of
the
the
water
stenosis?
is
Okay,
sensitive
so
and
Yes,
Because
yes,
of the
yes.
stenosis, there will be shredding of blood
So we have one
cells.
Willebrand factor, right? One Willebrand factor is a very sensitive thing, right? It is a very sensitive thing, right? Just think of one Willebrand factor as a car, right? And this car is going through a highway, right? And this is the highway. All of a sudden, this highway becomes very small. What is going to happen? The car is going to get crashed. This thing is going to gonna get removed. This thing is going to get removed, right? So these things are going to get removed. So basically, this is what happens in aortic stenosis, right? In aortic stenosis, these areas are going to be narrowed, right, like this, right? These areas are going to get narrowed, right? And when these areas are going to get narrowed, right, the von Willebrand factor is going to decrease, right? It's going to decrease in quantity, right? The von Willebrand factor is going to decrease in quantity, right? And then you are going to have von Willebrand disease. So aortic stenosis patients usually have von Willebrand disease. What is the reason these patients have von Willebrand disease? Is the fact that a von Willebrand factor get destroyed, right? When we'll do GI, I'll tell you a syndrome which is known as the Hades syndrome, right? Right? Is that clear? Okay. Can we move forward?
Yes, doctor.
Okay. Just give me 1 second, guys. Narrowing of aorta? No, 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 no. Basically, if this is the left ventricle, we have a valve here, which is known as the aortic valve, right? Yeah, we're gonna have GI bleed as well, which is known as the angiodysplasia, right? This valve is gonna get narrowed, right? And when this valve is gonna get narrowed, right, then there are gonna be problems. We'll move forward from here. So this was von Willebrand disease, right? The next disease that we're gonna do is DIC. So basically, DIC stands for disseminated intravascular coagulation, right? So okay, so before we'll do DIC net, right? We are first gonna do all the factors, right? So there are thrombophilias that we are gonna do. Yes, Shitty syndrome. So let's go over that. So what are hereditary thrombophilias? Now these are the disorders in which the bleeding was increased. Now we have some disorders in which the bleeding is decreased and there are increased chances of coagulation, right? There are increased chances of coagulation and the bleeding is decreased, right? What are those disorders? How do they occur? There is hypercoagulable state in these disorders, right? And why do we have a hypercoagulable state in this disorder? We'll have to go through that, right? Any questions till now? If not, then we'll move forward.
So, Dr. Muaz, I have one question.
Yes.
So yesterday class actually I couldn't attend, so that's why maybe I have one confusion. Why in bone almond disease the prothrombin time no change?
Mm-hmm. Can you tell me again?
In bone almond disease, prothrombin time would be increased, decrease, or there would be no change.
The clotting time?
Prothrombin time.
Yeah, prothrombin time is not gonna be changed. Why? Because I
Mm-hmm.
told you guys what is the thing on which prothrombin time depends upon.
Seven.
Factor 7. So von Willebrand disease does not have von Willebrand disease does not have. Just give me 1 second. Yes. So the thing is, von Willebrand disease, factor 7 PT time is gonna be affected whenever there is gonna be any problem. And what do you say? Factor 7, prothrombin, right? So prothrombin and factor 7 are related to each other, right? If there is a problem in factor 7, then prothrombin time is gonna be affected. Is there any problem in factor 7? In case of von Willebrand disease?
No,
No,
no
No.
problem.
So if there is no problem, yes.
that's factor 8.
Yes. So factor 7 is usually affected in liver diseases, right? So if a person is having a liver disease, then his factor 7 is going to be affected. But no, here factor 7 is not going to be affected. So That is why prothrombin time is not gonna be increased. In the end, I'll go over all of these. What time did you guys start? We started at 8:30 something, right? We started at 8:30 something. Okay. Right. Okay,
Okay.
let's move forward. I'm gonna tell you all the coagulation disorder labs in the end again, right? I'm gonna revise it for you. So we are going to hereditary thrombophilias, right? So thrombophilia. So basically, thrombo means a thrombus and philia means loves, right? So thrombophilia means love for thrombosis, right? Love for coagulations, right? So basically, this is what how hereditary thrombophilias mean, right? It means love for thrombosis. Then this is a very important thing, right? So first of all, we have. I'm gonna tell you some things, right? First of all, we have a thing which is known as the antithrombin thing, right? What is antithrombin three? Anyone?
It inhibits the thrombin.
Anyone else?
Prevents thrombosis.
Thrombosis? No.
Inhibit thrombosis.
Yeah, how does it do that? That's the point. I know it will obviously it's antithrombin, it's gonna inhibit thrombosis, but how? This is important.
It is anticoagulant and it blocks the effect of thrombin.
Okay. So
Yes.
basically it blocks two factors, right? First is the factor 2, right? Second is the factor 10. Remember these factors. It's gonna block factor 2, it's gonna block factor 10, right? It's gonna inhibit these factors, right? Is that clear? So what happens is that how does it work, right? Basically, normally normal patients it does not do anything. In normal person, it does not do anything, right? In normal people, it won't do anything. But when you give a person heparin acts on antithrombin 3, right? And it activates antithrombin. When antithrombin 3 is activated, factor 2 and factor 10 are gonna be deactivated, right? So the problem occurs is that a lot of people, some people have antithrombin 3 problem, right? Their antithrombin 3 is resistant, right? So they have resistance of antithrombin 3, right? So basically we have factor 2 and factor 10, right? So I'm gonna give you a first a context, right? So basically what happens normally is that in normal people, right? In normal people, we don't need these. In normal people, factor 2 and factor 10 are working, right? But sometimes if a person is having heart attack, if a person is having a stroke, what is going to happen is that we need to inhibit these factors because these factors are going to be overworking and they are going to be causing a lot of coagulation, and we don't want that coagulation to happen near us, right? So how do we prevent that coagulation? In order to prevent that coagulation, we shut off factor 2 and factor 10. In order to shut off factor 2 and factor 10, we have a thing which is known as the antithrombin, right? Antithrombin is usually present in the body but is not activated. In order to activate it, we give up thing which is known as the heparin, right? So what is happening gonna do? Heparin is gonna activate antithrombin 3, right? And when antithrombin 3 is gonna get activated, right? Factor 2 and 10 are gonna get deactivated. Okay. But some people have antithrombin 3 resistance, right? So if even you give heparin to that patient, it's not gonna act. Normally we don't know who are the patients who are going to have antithrombin 3 deficient resistance or deficiency or resistance, right, but so your this is what is going to happen. The patient is going to come with MI, you're going to give the patient antithrombin 3, right? And then the question is going to mention after giving heparin. So normally if we give a person heparin, which laboratory parameter is going to be affected?
PTT.
PTT, right? PTT is going to be affected. Okay, normally PTT is going to be affected. Okay, but in this case PTT is not going to be affected. Why? Because antithrombin 3 is absent or it has a resistance, right? Sometimes it's genetic, sometimes genetically antithrombin 3 is absent, right? But in other cases there are other reasons it could happen as well, right? And what are those other reasons in which it could happen, right? The first most important reason is that a patient is having a nephrotic syndrome. You guys remember nephrotic syndrome?
Yes.
So what happens in nephrotic syndrome? No, no, no. Heparin affects only PT. Guys, I don't do this to me, please. Heparin. Okay. So what factors does heparin act on? Anyone?
2 and 10.
2 and 10, right?
And 10. Yeah.
And their intrinsic factor.
Yes. What does it work on the factor 7?
No,
Uh,
No,
So
no.
no.
if it works on factor 7, then it's gonna affect the prothrombin time. Then
Yeah.
we have another very important drug which is known as the warfarin, right? Which factors do warfarin block the production of?
10 to 7.
it's 2, 7, 9, 10.
2,
2,
7, 9,
7,
10,
9,
which are
10.
vitamin K dependent.
Yes.
Yeah.
2, 7, 9, 10. The most important here is 2, right? 7. So 7 is the PT factor, right? So PT is going to be increased with warfarin, APTT is going to be increased with heparin. This is a very important difference between both of these. Okay. So now if a person has nephrotic syndrome, that person is gonna lose proteins in the urine, right? And antithrombin is one protein that a person can lose in the urine, right? And when a person loses antithrombin 3 in the urine, the person is gonna get hypercoagulable. So now basically whenever a patient is having nephrotic syndrome, this patient is not usually going to have a coagulopathy, right? And when the patients have like hypercoagulable state, they are going to ask you what is the mechanism of action, right? And then they could ask, that's heparin, what? And that's warfarin, what is
We
warfarin?
definitely say
Hmm?
2, 7, 9, 10. That's what
Okay.
is answer.
Okay. Yeah. So basically this is the thing that happens usually. Okay. So let's move forward to the next one. The next one is the most common mutation, right? So we have a factor which is known as the factor 5, right? We have a protein which is known as the protein C. So what is the function of, can you compare antiphospholipid antibody syndrome for antithrombin 3 deficiency? Yes. Like, do you want me to compare them side by side? Okay, sure. Okay, so red light Apla syndrome. This is, I'm gonna call it Apla, right? This is the Apla syndrome, anti-phospholipid phospholipid antibody syndrome. This is the what was the other one? The other one was antithrombin 3 deficiency, right? Okay, let's compare them. So what happens in Apla syndrome, right? So guys, I found a very good app for you where for step one, right? It's very good, but I don't know if it's paid, right? I don't know if you can have the access or not, but there are very good questions in it, right? The questions in it are very, very good, right? It's a it's based on like that app is based on NEJM, right? So NEJM stands for New England Journal of Medicine. It's the basically the best journal for medicine. The questions there were really good. I tried them today, right? I could share the link of the app link, right? I have the app link, but it's free for us. I don't know if it's free for you or not, right? Maybe I could give you questions from there, or so you could prepare some topics, right? So basically, Apla syndrome, what happens is that we have antibodies, right? We have antibodies that causes thrombosis all over in the body, right? So basically, we have antibodies that activate coagulation, right? These antibodies are gonna work on the coagulation, right? It's going to activate coagulation, and whenever there is going to be coagulation, there is going to be thrombi throughout the body. Okay, this is antiphospholipid antibody syndrome. In antiphospholipid antibody syndrome, there is going to be an artifact, right? And the artifact is that the patient is APTT is going to be increased, right? Usually, when does APTT increase, guys?
In hemophilia.
Mo-
Yes, in hemophilia, right? So in hemophilia, APTT is going to be increased, or if you are giving the patient warf have heparin, the APTT is going to be increased, but usually it does not get increased, right? Usually it does not get increased, right? Now let's move forward. Whereas in antithrombin 3 deficiency, what is going to happen is that antithrombin 3 is going to be absent, right? Or its function is going to be reduced, right? But if you look at these patients' APTT, it is going to be decreased, right? If you look at these patients, APTT is going to be decreased, right? So basically, this is the difference, right? APTT is going to be decreased. Why? Because heparin cannot act, antithrombin 3 cannot act. The half life of 2 and factor 10 and 8 is going to be increased, right? That is what is going to happen. Is that clear? Okay.
Yes, it's clear, but
Hmm.
yesterday you said that when you were talking about antiphospholipid antibody syndrome, I noted it down. Maybe I noted it wrong, but you said that antithrombin 3 attaches to factor 8 and deactivates it. So bleeding occurs. Is that wrong?
Uh-huh. What did I say? Can you tell me again? I did I talk
Antithrombin
about antithrombin 3 yesterday?
in antiphospholipid antibody syndrome.
Yeah, so what did I say?
You said that it destroys the antibodies destroy protein C, S, and antithrombin 3.
Mm-hmm. Check. Uh-huh.
It's
I
just
think
because I noted
it
it down.
said,
I could be
it
wrong.
said, I think it said antithrombin 3 destroys factor 8. I don't know if I also
Yeah,
made.
exactly,
Yes,
exactly.
yes. Antithrombin 3 is gonna destroy factor 8, right? That's right.
Okay, yeah, that's what I was confirming.
So
Okay.
basically, see, antithrombin 3 is gonna act on. So antithrombin 3 acts on. Antithrombin 3 is gonna act on factor. So basically, okay, let's go back a bit, right? I think I should explain first another thing to you guys so it becomes clear, right? We are already ahead of our schedule, right? We don't need to rush anything, right? So I'm gonna try to explain things better, right? So basically, coagulation. So basically, we did it till yesterday. So I'm gonna do some physiology as well, right? So is everything clear about platelet plug formation?
Yes.
Okay, so now
Yes.
we'll move. Yes, so now we'll move on to the next topic, right? So when the platelet plug is formed, the platelet plug is a very loose thing, right? It's not gonna do anything for you, right? It's not gonna do anything for you. Okay, so what we are gonna do is that we are gonna make this platelet plug strong, right? We are gonna make this platelet plug strong, right? We want this platelet plug to be strong as possible, and in order to make it as strong as possible, we have to add fibers in it, which is known as the fibrin, right? So if this is a vessel which is damaged, here is the platelet plug. This platelet is a just like a tape, right? So for example, if a pipe is bleeding, it's just like a pipe, right? So for example, you have a pipe and a pipe is bleeding, right? If you attach a tape over the pipe, how long will the tape stay there? Anyone? And will it
Short
will it
time.
stay? It will
A short time.
yes, short time. So in order to make that tape stay there for a longer, we use glue. We can use alpha, we can use glue, we can use epoxy resin, right? Do you guys know epoxy resin?
Yes.
Yes.
Yeah, so basically we use epoxy resin or that kind of stuff to make it fix there, right? So here we do the same thing, right? First of all, we are gonna make a platelet plug, and after making platelet plug, we are gonna make it strong by using fibrin, right? So in the platelet plug, we are gonna enter fibers. That fiber is gonna make the platelet plug stronger. This action of making platelet plug stronger is known as the coagulation pathway. Okay, so we have two coagulation pathways that go on in our body, right? One is the intrinsic pathway, the other is the extrinsic pathway. Okay, is that clear?
Yes.
Both of these pathways work by different things, right? Intrinsic pathway are, are works on different factors, right? Extrinsic pathway works on different factors, right? Is that clear? Now, there are some common molecules between both of these pathways, and there are some unique molecules between both of these pathways, right? So, the most unique molecule, what do you think is the most unique molecule between extrinsic and intrinsic pathway? What are the two most unique molecules?
7 and 8.
7 and 8, right? 8 is specific to an extrinsic pathway, right? 8 is so there is a mnemonic for that, right? Guys, are you getting me? I don't want to just speak and speak. Like, I swear, right?
You're
It's
getting you.
I'm
Yeah, we are
I
getting.
it's very hard for me to speak right now, but I'm doing it, right?
Yes.
I'm not getting paid for it as well. I'm doing it voluntarily right now. Okay? I'm just doing it for you guys, right? I'm not getting paid for it. Okay? For these sessions and lectures and everything, right? First I did get used to paid, but not anymore, right? So now like the admins don't even reply me. So but since you guys are paid, I'm doing it. Right? Okay. So there is a mnemonic, right? PTT stands for play table tennis inside. Wasn't wasn't understanding initially because I didn't have clarity about physics. Okay. So PTT stands for play table, yeah, but it's not it's meaning. Okay, so PTT stands for play table tennis inside, right? PTT stands for play table tennis inside. So PTT stands for intrinsic pathway, right? And PT stands for play tennis outside. So right, play tennis outside. So you play tennis outside, you play table tennis inside. Is that clear?
Yes.
So we play table tennis inside so obviously PTT is gonna stand for the intrinsic pathway, and intrinsic pathway is gonna involve the factor 8, right? And then extrinsic pathway is gonna involve the factor 7. Okay, is that clear? Now what is gonna happen is that we're gonna go through both of these pathways, right? So when do we use the intrinsic pathway? When do we use play? Okay, so when do we use the extrinsic pathway? When do we use the intrinsic pathway? It's not important for USMLE, but it's an interesting thing, right? It's an interesting thing. So I'll go over it too. Oh my god. So basically, whenever there is a damage inside the vessel, then the intrinsic pathway, it means it acts from inside. Intrinsic pathway is going to be activated. Whenever there is damage from outside the vessel, for example, a tissue trauma, there is a tissue, there was a blood vessel that was damaged from the outside, then it's going to be the extrinsic pathway, right? So keep this in mind. Intrinsic inside vessel, extrinsic external trauma. Intrinsic inside the vessel, extrinsic external trauma. Right. Now let's go over one of the extrinsic pathway. But don't need to remember all of this stuff, right? Just gonna tell you something, right? So where does the extrinsic pathway starts from? Extrinsic pathway is gonna start from the factor 7, right? Then factor 7 is gonna activate factor 10, right? And factor 10 is going to activate factor 5, right? And factor 5 is going to activate factor 2, factor 2 is going to activate factor 1, and then you are going to have a fibrin mesh, right? You don't need to get into the detail of it, right? So you can see how all of these molecules are playing an important role in activating each other, right? So in intrinsic pathway, factor 12 starts. Factor 12 is going to activate factor 11. 11 is going to activate 9. 9 is going to activate uh, the next one. Okay. So 10 is going to be activated. It's going to activate 5. 5 is going to activate 2. So basically, this is what is happening in case of the extrinsic pathway. Is intrinsic pathway. Is that common? Hello, guys.
Yes.
From
Okay.
10 onward
Yes, from
is
10 onward, we go into the common pathway.
Yeah,
Yes.
so basically from 10
Overlapping.
onwards, from 10 onwards, we go into the common pathway, right? So this is the common pathway. If anything's right, this is a common pathway. Up to that, it's not common, right? Now let's move forward. Now the thing is that So basically, now tell me, what does PT measures?
Extrinsic.
Extrinsic factor.
Yeah.
Extrinsic.
Factor 7.
Extrinsic, right? So it depends upon the factor 7, right? Where is happening working? On which factor?
2 and 10.
2 and 10. So this is 10, this is 2, right? Does it affect this area?
No, it doesn't.
No,
No.
so it's not gonna affect the prothrombin time, right? Similarly, right, this is the area of other one, right? And this is the area of warfarin, right? So does warfarin affect the other one? No.
No.
No, it
Okay.
doesn't.
So this is how it works, right? So when we do all of these things, we're gonna come in the end and see how all of these things are interacting with each other and why are they playing an important role in each other's life, right? But before that, we are gonna move forward, and that is gonna be the factor 5 leader, right? So basically, we have a protein C, right? Have you seen factor 5? So basically, everything was activating factor 5. So there is a protein which is known as the protein C. So protein C destroys factor 5. But sometimes there is a mutation in factor 5, so protein C is not going to get deactivated, right? So when protein C does not get deactivated, you are going to have, when factor 5 does not get deactivated, you are going to have a lot of coagulopathy. You are going to have a lot of coagulation throughout the body, right? A lot of coagulation is going to be present throughout the body, and this is going to occur, right? So this is known as the factor 5 leaden mutation. Basically, this is the most common cause of genetic coagulations, right? So if a person said that I am having coagulation disorder, my whole family had coagulation disorder, and then they ask you what would be the most likely cause of this coagulation disorder. So for example, a person comes to you and that person is 20 years old, and this person had history of 4 or 5 DVTs, and his brother had history of 4 or 5 DVTs as well, and now they come and ask you what is the most likely cause of this patient's DVT. So the most likely cause is going to be a factor 5 leaden mutation, right? Okay. So protein C, remember protein C, it cannot be degraded by protein C. Similarly, we have a protein S, right? So what is going to happen is that protein act is S is going to activate, protein S is going to deactivate factor 5 and factor 8, right? Protein C, S is going to deactivate factor 5 and factor 8. So factor 5 and factor 8 are not going to get deactivated, right? Uh, Factor 5 and factor 8 are not going to get deactivated, right? So whenever you have this problem, so remember, if protein C and protein S are deficient, right, factor 5 and factor 8 are not going to get deactivated. Is that clear, guys? Now,
Yes.
Yes.
yes, now next step is basically blood transfusion therapy. You're not going to go into a detail of this. I'm just going to tell you a bit. So if you give a person a packed red blood cell, obviously it's going to be due to hemoglobin and O2 binding capacity. You don't want to remember this, right? As well, right? So if you give 1 unit of blood, the hemoglobin should rise by 1 gram per deciliter, right? And hematocrit is 3%. You don't need to remember this shit. Oh my god, I am sorry. So you don't need to remember all of this. You can just leave this. Just leave this thing. One important thing is that whenever you give transfusion to a patient, always remember, if you give a transfusion to the patient, what is going to happen is that this patient can have hypocalcemia. Why? Because the the elements that are present in the blood, they are gonna stick to the calcium and they are gonna reduce the calcium, right? So there's gonna be hypocalcemia, right? Is it clear?
Yes.
We're not gonna do
Yes.
the Hodgkin lymphoma today. We are gonna do some physiology. We still have time left, right? We're gonna do some physiology. These 2 pages are done, right? I'll go into more detail about coagulation and kinin pathways just tomorrow. Have you done? Oh, DSC is left. For DSC, we have to do all the factors first. Then we'll
Yeah.
move on to DSC. Yeah.
Dr. Moss, hypocalcemia in case of packed cell transfusion.
Yes. So whenever you give a patient blood, especially if a patient had accident and you give a lot of blood to the patient, we have calcium. We have citrate in the blood, right? Right. So that citrate binds to the calcium and it forms calcium citrate.
You need
That's
it as
why
a
we give,
vitamin.
Dr. Kumar, that's why we give calcium gluconate after blood transfusion for this.
Yes, yes, yes. Now, now we have new bloods that don't have a lot of problem. They don't even can contain citrate, but there we still have bloods that contain citrate, so we are gonna have a problem in those things, right? Okay, let's move forward. So the now we are gonna do some hematopoiesis.
Doctor, I
Okay.
have a question.
Yes, sure. Ask away.
So, in the extrinsic and the intrinsic pathway, there are some factors that are common in
Hmm.
intrinsic and also common in extrinsic.
Yes.
Does that give any indication,
Mm-hmm. Like what indication?
like during the coagulation phase?
Uh, I did not get your question. Could you please repeat it? I'm sorry.
Okay, I'm seeing that there is factor 2 that is, I don't know, maybe I can be wrong. Factor 2 is also in intrinsic and is also in extrinsic pathway.
Uh-huh. Huh. Yeah,
Yeah.
yeah, it's common.
In case of their
Okay.
deficiencies, PT and APTT both will be deranged or
So, so if there's a problem that engulf this factor 2, so the PT will be affected and the PTT will be affected too. That's what I want to.
Mm-hmm. Mm-hmm. I got your point. I got your point. So remember, guys, PT is gonna check the activity of factor 7. Right? Only factor 7, nothing else. Yeah. Okay, I'm gonna tell it. Right? And APTT is gonna check the activity of factor 8 only. Right? It's gonna affect the activity of factor 8 only, nothing else, right? So remember this thing. If you look at this thing, if factor 2 is blocked, right, it's not gonna affect factor 7's activity, right? And it's not gonna affect the factor 8 activity as well, right? Is that clear? So why does heparin then affect factor 8 levels? This is a very good question, right? This is a very good question because you can say, Dr. Moaz, heparin is antithrombin 3 is acting on factor 2 and factor 10, right? And these are in the common pathway, right? Why? Whereas the thing that was mainly was that heparin, you need factor. So basically, mainly PTT was checking factor 8, right? So this is what was happening. Okay, so while I'll tell you how does this happen, right? Just give me. So basically, antithrombin 3 just does not cleave factor 2 and 10. There's another important factor that it cleaves, and that is factor 9. So this is the factor that it cleaves, right? So if this is affected, factor 8 is gonna be affected with it as well, right? So this is how we are gonna know that there's a problem of factor 8, right? So basically, PTT is gonna measure factor 8 and PT is gonna measure factor 7 and APT is gonna measure factor 8. Okay. I hope I don't confuse you anymore. Is it clear everything?
Yes.
Yeah.
Mm-hmm. Okay. Okay. Is that clear?
Yes, Dr. Kumar.
Any more
Yes.
questions?
Yes. Thank you.
You're welcome. I think we can keep it till here today and we can start from tomorrow. Okay?
Okay, thank you.
Oh, yeah, you're welcome. Tomorrow I'm gonna be free, right? I finally have a off. Okay, so we can do maybe 2 hour, 3 hour session, right? We'll try it. Would you suggest we give for physio or read? No, no, no. I'm gonna teach you all the physio. Don't worry. I'm gonna teach you all the physio. I'm not gonna even leave one word out of it, right? If you want to give it a read for your on self, you can, right? Like if you want to do it, you can, but I'm gonna teach it as well, right? It's up to you. If you wanna do it 2 times, it's okay, but I'm gonna teach it as well. Don't worry, I'm gonna teach it as well. Okay.
Tomorrow is
Yeah,
at what time? Eight?
Mm, what time? Okay, so I want maximum. There was a time 60 people were present in the lecture, and now only 35 are present, and this like really makes me sad.
No, it's
Like,
because of the time, doctor. Some of them
uh-huh,
don't. Mhm.
uh-huh. So, yep, maybe we can do some else tomorrow
I
anemia.
think the same
So,
time is better because most of the people are have read
mhm.
Working and
according to this time.
Okay, so we will do. Okay, so we will do anemia tomorrow. All of the anemias, they are very big. I'll try to make up for all of them. Okay. Okay. Bye bye, guys.
Dr. Mars, please don't forget to send the link you mentioned of sending earlier.
Oh, the open evidence thing.
Yeah.
no, the AI.
Yeah.
The question you talked about that you would share the link with us.
Oh, so basically that is an open evidence. It's a very good software, right? I really like it. It's an AI based software. It's a new software that came out, and there was step two and step one, step three resources on it as well. Uh, yeah. So yeah, I'll share it with you guys, right? I don't know if you would have the access or not, right? So you need an NPI number for that. But what is the name? It's open evidence, right? You can check it. It's more advanced, right? But you can find good things. You can search anything on it, right? You can search basically anything on it, right? So you can search anything. It's an AI based healthcare, right? Okay, so three questions are free on it. If you want to do, three questions are free on it, right? So for example, if you ask anything to it, it's gonna tell you about anything, right? So if, for example, if we ask it, so I have opened it yet, I don't know if I can share the screen or not, but if you ask it why NPI number, yeah, you need NPI number for that. So if you ask why is APTT increased with heparin, right? It's gonna give you a very good answer, right? It's gonna give you an evidence. So remember one thing that I'll tell you guys, right? Never ever use Chat GPT for medical knowledge, especially steps, right? Please don't use Chat GPT for steps. Why? Because Chat GPT never gives the right answer. It never gives the accurate answer. I have tried it multiple times and it fails very badly, right? If you are gonna use Chat GPT, I won't recommend anyone to use Chat GPT, guys. Okay, Chat GPT is very, very, very bad. It's notoriously bad, right? There is one thing in Chat GPT which is known as hallucinations, right? So one of a person I knew was did a research on this thing. So for religious purposes and for this ones, you cannot use ChatGPT. Why? Because ChatGPT hallucinates. It makes up facts that are not present in real life, right? And it states the fact with very strong confidence. So you're gonna believe what ChatGPT is gonna say. ChatGPT is gonna say, "Hey, this is this and this is," but in reality, this is not gonna happen, right? Okay. So remember, avoid ChatGPT for steps as much as you can. Factor, right? Any more questions?
Dr. Moaz,
Yes.
please, I want a clarification, right? So you said in APLA, patients with APLA, hemophilia, and von Willebrand have something to do with APTT, but in
Uh-huh.
APLA and hemophilia, APTT is increased, right? And then
Uh,
in von Willebrand's, it is decreased. Is that correct?
in Volpinib brand?
APTT is decreased.
No, it's increased in Volpinib brand. Okay,
Okay, so it's increased
I'll
in the
ask.
three of them. It's increased in the three of them.
Yes, but
Okay,
yeah.
I just wanted that clarification. And then
Mhm.
what about the factor eight? Is it deficient in the three of them as well?
No, 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 no. So basically, in hemophilia factor, it is deficient. All right. I'm gonna make it clear for you, and I'm gonna make your answer and make your understanding clear. So, what happened in what happens in von Willebrand disease? Like, just simply tell me why. What's the pathophysiology? Simple. What is deficient in von Willebrand disease?
That would be factor eight, correct?
Yeah, basically one Willebrand factor, and then one. So basically, hemophilia has deficiency of factor eight. One Willebrand has deficiency of one Willebrand factor. But now, what is gonna happen is that one Willebrand factor. Okay. So what is going to happen is that von Willebrand factor protects factor 8. So when there is von Willebrand disease, the factor 8 is going to be decreased as well, right? But the main difference that comes is it's not going to be decreased like super crazy decrease. It's going to be a mild decrease, like 50% decrease. Whereas in case of hemophilia, the decrease is going to be like 5% or like so or so in that range. It's going to be decreased a lot, right? So when factor 8 decreases, right, what is going to happen to the APTP?
APTT will increase.
APTT will increase. You are exactly right. But in case of APLA syndrome, in case of APLA syndrome, so basically, hemophilia and von Willebrand disease are disorders of bleeding, right? There is going to be increased bleeding in both of these disorders. Okay, in both
Mm-hmm.
APLA and hemophilia, there is going to be increased bleeding, right?
Yeah.
So keep that in mind. Okay. Oh, whereas in the other one, right? Uh, whereas
In
the
APLA.
in the APLA, right? The
Mm-hmm.
bleeding, there is going to be increased amount of coagulation, right? The APTT increase in APLA is just an artifact, right? It's an artifact. It's not a real thing. Okay.
Okay.
It has nothing to do with factor 8. It's just a laboratory thing that is present. Okay.
Okay.
Okay. That's fine. Okay, guys, we'll keep till here today and start from tomorrow. Okay. Okay. Bye bye. Bye bye.
Thank
Yeah,
you.
bye.
Bye bye. Bye bye.
All right.
Bye bye.